Hello everyone. Today we are going. Family planning is said to be as old as human existence itself. Prehistoric records show that in the past, people go through seemingly ridiculous means to attain contraception, like using crocodile dung as vaginal plugs or pessary, or making a concoction of herbs, fruits, and nuts to use as spermicides. In our own setting, we too have our own herbs identified by our herbolario as a contraceptive agent. As to its efficacy, well, that remains to be seen. In the 12th century Philippines, there was supposedly a document, the Code of Kalantiao, that describes how family planning was done. It states that a man cannot have a wife that is too young, nor have more than two wives if he cannot afford. Otherwise, he would be punished or killed. The effect of the population problem was beginning to be felt by the world. In 1967, UN member nations gathered for the UN Declaration on Population, which states that the population problem must be recognized as a principal element in long-range national planning. In response, the Philippines in 1969 established Executive Order 179 called the creation of the Commission on Population. Today, we are 110 million Filipinos. We rank number 13 among countries with the highest population. Of course, China and India occupies the number 1 and number 2 posts. So, rapid population growth is indeed a threat to human survival. And yes, there is a need for family planning. The COVID-19 pandemic is expected to aggravate this population problem. According to the UNFPA, 19% of women aged 15 to 49 have unmet need for family planning. That means to say they have no access to family planning services. And this would in turn result to increased unwanted pregnancies, decreased use of contraceptives leading to undesirable pregnancy-related outcomes, and increased morbidities that will overwhelm an already strained health system. All this because of fear of COVID-19 and stay-home policy, especially those of the 15 to 21 years of age. So what then is the ultimate goal of family planning? Primarily, it is to improve the quality of life by birth spacing, allowing the mother to rest to regain health, birth limitation, you have a desired number of children, and helping infertile couples to have children. Let us look first at the reproductive capacity of the female sex. Baby girls at birth have 1 to 2 million primordial follicles. At menarche, this is decreased to 300,000 to 500 oocytes. So between menarche and menopause, the female sex have a 30 years of ovulatory reproductive cycle. That means to say they are capable of having 30 or more babies. Besides the reproductive potential of women, there are also those who do not use contraceptive methods because of the following reasons. Ignorance, they don't know anything about it. And then others, fear of the irreversibility of fertility. That means to say they are afraid that they won't get pregnant anymore if they use contraceptives. And then there is unwanted side effects like increase in weight, high cost, and then difficult to administer because one needs to go to the health center or to the hospital for it to be administered, like injectables or the implants. And then others would prefer the use of traditional methods. When you consult patients seeking contraceptive methods, you should always emphasize that no contraceptive method is 100% effective. However, you should also say that contraception poses less risk than pregnancy and can provide non-contraceptive benefits, meaning that the unwanted effects or risk in taking or using contraceptives is minimal compared to the risk of being pregnant and its potential life-threatening complications like hypertension, diabetes, or bleeding disorders. The efficacy of contraceptive methods is evaluated according to the following: method failure rate or failure rate inherent in the method if used correctly 100% of the time. An example of which would be a woman getting pregnant after a bilateral tubal ligation. And a typical failure rate or failure rate seen as the method is used by patients factoring in the mistakes in usage. Like for example, a woman taking oral contraceptives after menses stop rather than on the first day of menstruation. This diagram shows the effectiveness of certain family planning methods. From those the least effective, no, that would include natural methods of family planning and barrier methods, with the most effective would be the long-acting reversible contraceptives and of course sterilization. In choosing a contraceptive methods, the following factors are being considered: safety, accessibility, affordability, and personal accessibility. Would it not be in conflict with their cultural or religious beliefs? And then, which of the couples would be responsible in having a contraception? Would it be the husband having a vasectomy or the wife having a ligation? And then others would be considering its protection against STDs. In 2010, WHO developed evidence-based guidelines for contraceptive use, called the USMEC. This was further revised in 2016. This consists of recommendations for using specific contraceptive methods of certain characteristics or medical condition. This is used as a guide for healthcare providers. The US MEC chart looks like this. It is even downloadable and it has an app. The US MEC chart has recommendations on the use of certain types of contraceptive methods when used in patients with medical conditions. So the categories would range from 1, no restriction, to 4, as contraindicated. So example, women who smoke and using contraceptive use. The one here has no restriction, so this would include the long-acting reversible contraceptive methods and the progestins. However, with combined oral contraceptives, those women aged less than 2 would have the category 2. However, if the woman smokes more than 15 cigarettes per day, then it is contraindicated for her to use the combined oral contraceptive. To be able to reach a lot of women and couples regarding the use of contraceptive methods, WHO and CDC have simplified their recommendations on the use of contraceptives. That is, there is no laboratory test needed to initiate contraception, and only blood pressure is required for initiating combined oral contraceptives. And pap smear is not even necessary before IUD placement. Furthermore, if a woman develops PID or pelvic inflammatory disease with an IUD, no need, removal of the IUD is not necessary. Antibiotics is sufficient. So these are the specific contraceptive methods that we will be discussing one by one today. So the long-acting reversible contraceptives or LARC includes intrauterine devices or IUDs and implants. Now the advantages of this would be they belong to the most effective means of contraception, and they are not user dependent, and they have high continuation rates and high satisfaction rates. So these are the long-acting reversible contraceptives. This is the copper containing IUD, and this one The more expensive intrauterine system, or exemplified by the Mirena or levonorgestrel containing IUD, and this is the implant. So let's talk about intrauterine devices. All IUDs are effective with less than 1% failure rate, similar to a bilateral tubal ligation. There are two types of IUD, each with chemically active components. One contains copper, the other is progestin. So for the progestin, this is Mirena or the levonorgestrel intrauterine system. You can use this for 5 years. And the other one is the Paragard or the T33080 IUD containing copper, which can be used for 10 years. This is the one commonly used in the local health centers or in our setting. Once removed, infertility is immediate. The mechanism of action of the copper-containing IUD would be spermicidal, so it interferes with sperm transport. And it also induces an intense inflammatory response within the uterus, making the endometrium hostile for implantation because it's a foreign body. However, discontinuation is due to severe dysmenorrhea and increase in menstrual flow. Complications of IUD use includes perforation, especially during insertion, identified by the tool or string traveling further than the expected uterine length on bimanual pelvic exam, and expulsion, especially in nulliparous or those inserted immediate postpartum because the uterus sealing process of involution, and menstrual changes or irregular spotting, infection during the first 20 days post-insertion, and abortion if pregnant. Now, if a patient is pregnant, the tail will be visible up to 14 weeks, and if seen, should remove the IUD. Otherwise, the following complications would happen: subsequent abortion, chorioamnionitis, and preterm birth. So how is the IUD inserted? First is you have to identify contraindications like uterine abnormalities. You have to obtain a written consent, and you can give oral analgesic prior to the insertion. And then you have to do a bimanual pelvic exam to identify uterine position and size. If the patient has infection, then you have to treat it before insertion. So this is how you insert an IUD. It is inserted through a tube into the uterus. So this is the tube. It's just like a guide, and this one, the curled portion, is the IUD. So after you have reached the fundus, you remove now the tube. So the IUD is released. So this is the IUD, and then you pull the tube. And so the IUD is now in place. Then the string, you have to cut the string just enough to be for the patient to palpate or for you to see the string if you follow up the patient later on. So when do you insert an IUD? Anytime if not pregnant, immediately after abortion or delivery, or after involution, so you wait after 6 weeks. Insertion techniques depend on uterine size. For placement not related to pregnancy, insertion near the end of normal menstruation when the cervix is usually softer and somewhat more dilated is recommended. This is how the IUD string would look like during a speculum exam. So patients should check the IUD string monthly. So you have to instruct them to palpate the IUD string. If there is suspicion that the device is not positioned correctly, then placement should be confirmed using an ultrasound if necessary. With misplaced IUD or you cannot palpate the string, you have to do immediate physical removal. So now let's go to the progestin implant. This is exemplified previously by the implanon, now it's called the Nexplanon. This is a thin, pliable progestin-containing cylinders that are implanted subdermally and can release the hormone for 3 years. So this is the implant. This is effective within 24 hours after insertion. So the implant is placed subdermally on the medial surface of the upper arm 8 to 10 centimeters from the elbow in the biceps groove and is aligned with the long axis of the arm. During replacement, you can do it at the same site. So after you remove this one, after 3 years, you remove this one, you can immediately insert another one, or you can do it on the opposite arm. So timing of the progestin implant would be ideally within the first 5 days of onset of menstruation. And then for those transitioning methods or those who want to change, an implant is placed on the day of the first placebo COC pill. A pill has 21, the usual pill would consist of 21 tablets. So the last 7 tablets are placebos or vitamins. So you can insert an implant during the first day of the first placebo pill. And then you can also insert it on the day that the next DMPA injection is due, or within 24 hours of taking the last progestin only pill. So related to pregnancy, an implant may be inserted before discharge, following delivery, miscarriage, or abortion. However, during this time, you have to give supplemental contraception within 7 days, or you tell your patient to refrain from having sex within the next 7 days upon insertion. So the mechanism of action of the progestin implant would be thickening of the cervical mucus. So it inhibits your sperm from entering the uterine cavity. It inhibits ovulation, and it can cause endometrial atrophy. The following are the advantages and the side effects of implants. The advantages would of course be convenient. You can just leave it there and forget about it for the next 3 years. And then it is rapidly reversible. So it is easy to remove. You can remove it anytime, and it does not affect bone density. However, the side effects because of its progestin content would be irregular bleeding, headache, and weight gain. So adverse effects of the implants would be mainly secondary to malpositioning. That is injury to the branches of the medial antebrachial cutaneous nerve if the implant or insertion needle is placed too deeply. So there would be numbness and paresthesia over the anterior medial aspect of the forearm. And then lost device or non-palpable device. So if the device is non-palpable, then you have to locate it through an ultrasound and remove it immediately once found. So let's now go to the hormonal contraceptives. This would include the combined oral contraceptives or the COCs, the progestin only methods. You have the DMPA, POPs, and the patch, and the transvaginal ring and the transdermal patches. The combined hormonal contraceptives contains both synthetic progestin and estrogen. So main effect would be the suppression of GnRH, blocks FSH and LH, and inhibits ovulation. So the progestin part suppresses LH, thus inhibits ovulation, thickens the cervical mucus, and makes the endometrium unfavorable. The estrogen part suppresses FSH release, stabilizes the endometrium, thus prevents breakthrough bleeding. So this would be exemplified by the pill, the COCs, and then the transdermal patch and the vaginal ring. Not all pills are alike. So the estrogen components in some would be in the form of ethinyl estradiol, mestranol, or estradiol valerate, while in others, the progestin would be norethindrone, levonorgestrel, drospirenone, ethinyl diol, desogestrel. So it is the progestin part that can have the unwanted effects. So the combined hormonal contraceptives also have unwanted effects, no? For the estrogen part, this would include breast tenderness, fluid retention, weight gain, nausea, and headache. And for the progestin part, it would be mood changes, fatigue, mild weight gain, and decreased libido. So the pill is user dependent. The greatest fear in the use of combined hormonal contraceptives is the risk for VTE or venous thromboembolism. So to minimize this adverse effect, there are now preparations with the lowest acceptable dose to prevent pregnancy and breakthrough bleeding. And the one that is currently used would be uh, estrogen content of 35 microgram or less. Now, the following contraindications with regards to the use of combined hormonal contraceptives would be checked with the US medical eligibility criteria, the one I've shown you before. So with the use of combined oral contraceptives, the following symptoms would often be presented by patients, no? Spotting, irregular menses, or nausea. However, these symptoms oftentimes resolve after 3 months. So you just tell your patient to take the pill regularly and observe for any other adverse effect because these effects usually disappear after 3 months of use. So the pill. So the pill comes in many preparations: monophasic, biphasic, triphasic, quadriphasic. So uh, those changes refer to the content of progestin per cycle. So how do you take your combined oral contraceptives or the pill? So you should take it daily for a specified time, 21 to 81 days, and then replaced by a placebo for a specified time, 4 to 7 days. So withdrawal bleeding is expected on the pill-free days. For general initiation, women should ideally begin taking the pill on the first day of the menstrual cycle. For maximum efficiency, pills should be taken at the same time each day. It may be started anytime, but if one dose is missed with higher dose COC, may continue as usual. If several doses are missed, then maybe stop and barrier techniques are used or start a new pack. COCs have method-specific effects. They can interfere with the drugs that you're taking, like anti-TB, anti-HIV. They can alter your lipids. That's why it's used with caution in patients with dyslipidemia. It can cause thrombosis and it can probably lead to stroke or MI. However, it has protective effects against ovarian endometrial CA, but has an increased risk of cervical dysplasia and later on probably cervical cancer. Other effects would include increased bone mineral density, it decreases menstrual blood loss, improves dysmenorrhea, and makes your face clearer. So the progestin-only contraceptive groups are the following: POPs, or the progestin-only pills, implants, and injectables, or the DMPA. The main mechanism action of which it suppresses luteinizing hormone and therefore blocks ovulation. So this would be in the form of cervical mucus thickening, which can retard sperm passage, can cause endometrial atrophy, irregular uterine bleeding, but with prolonged use may induce amenorrhea, weight gain and bone mineral density loss, and increase in the LDL but decreases HDL, especially the MPA. For the POP, or the progestin only pill or mini pill, you have to take it continuously, same time every day at 24 intervals. No placebo week. This is compatible with breastfeeding. The main mechanism of action does not reliably inhibit ovulation but has an effect on cervical mucus thickening and causes endometrial atrophy. So it would be difficult for a fertilized egg to implant. Fertility is restored rapidly following cessation. So if you miss a pill more than 4 hours, then you need supplemental contraception for the next 48 hours, like condoms, or refrain from having sex for the next 48 hours. For the progestin-only injectables, this is exemplified by DMPA, or the dipomedroxyprogesterone acetates. This is 150 milligram preparation given IM every 3 months, or the norepinephrine enanate, a 200 milligram preparation given IM every 2 months. The mechanism of action of progestin-only injectables would be ovulation inhibition, and it can increase cervical mucus viscosity, and it creates an endometrium unfavorable for ovum transplantation. So if given within the first 5 days, therapeutic effect is by 24 hours. However, you can give it as a quick start any day, but needs a pregnancy test and a supplemental contraception for 7 days. Then you repeat pregnancy test in 3 to 6 weeks. So advantages of the injectable progestins include convenience. Effect is similar or better than the combined oral contraceptives. You can use it for breastfeeding because it cannot interfere with your lactation, and it prevents anemia because it prevents heavy menstrual bleeding. The side effects would be irregular menstrual bleeding, or sometimes patients complain of vaginal spotting, delayed fertility resumption because it's depot. So it is in your the medication is in your subcutaneous area, and resumption to fertilization is unpredictable. So then it can increase stroke in those with severe hypertension. It can cause weight gain, and it can also cause loss of bone mineral density. However, this is reversible once you stop the injection. So there's also a transdermal patch. It has an inner layer containing an adhesive and hormone matrix, and a water-resistant outer layer. Its initiation is the same as the combined oral contraceptives. So you have to apply the patch, apply the patch weekly for 3 weeks, followed by a patch-free week to allow withdrawal bleeding. However, this has an increased risk of VTE. So this is an example of the patch and where you can apply it in the abdomen, upper outer arm, upper torso, or the buttocks. There is also a transvaginal ring. This is a flexible intravaginal ring. So the ring is placed within 5 days of menses onset. And this is placed for 3 weeks, then removed for 1 week to allow for withdrawal bleeding. The side effects would be vaginitis, ring-related events, or leukorrhea. I don't know if this is available in the Philippines. So now let's go to the barrier methods. This would be in the form of condoms, male and female, diaphragm plus spermicide, and the cervical cup. So this is the male condom. It is made of latex or polyurethane or lump intestine. Its contraceptive efficacy is enhanced by a reservoir tip and a spermicide. So lubricants should, if used with lubricants, it should be water-based. It can provide considerable but not absolute protection against a broad range of STDs. So the female condom, this is a synthetic nitrile sheet with one flexible polyurethane ring at each end. Its open ring remains outside the vagina, whereas its closed internal ring is fitted under the symphysis like a diaphragm. It should not be used concurrently with male condoms because simultaneous use may cause friction that leads to condom slipping, tearing, and displacement. This can be used with oil-based or water-based lubricants. This is impermeable to HIV and STDs. So following use, the female condom outer ring should be twisted to seal the condom so that no semen spills. So diaphragm plus spermicide. This is a circular latex dome of various diameters supported by a circumferential latex-covered metal spring. So this is effective with spermicides. It is inserted hours before intercourse, and it should not be removed 6 hours after intercourse. However, this can pose a risk for toxic shock syndrome and UTI. So there is also a contraceptive sponge. This must be inserted prior to sex vaginally and covers the cervix. This is 95% effective avoiding pregnancy. It does not prevent STDs. So another method of contraception would be fertility awareness-based methods. So these methods attempt to identify fertile days during each cycle and advise sexual abstinence during these days. There is an option for patients who do, This is an option for patients who do not want or cannot use other contraceptive methods. So this would include standard days method, 2-day method or the cervical mucus method, calendar, BBT, and simple thermal method. So the basis of the fertility awareness-based method would be pregnancy would most likely occur for only about 6 days in the menstrual cycle. And then the ability of the sperm to live in the female reproductive tract for 5 days, and the ovum would be viable within 24 hours. So the following women can choose the FAB methods. Those with irregular cycles, perimenopausal women, postpartum, post-abortion, breastfeeding, and recently stopped another form of contraception. So for the standard days method, this is for women who have regular monthly cycles of 26 to 32 days. So they have to avoid unprotected intercourse during cycle days 8 through 19. So this is usually done with the calendar method or the use of cycle beads. So this is the simplest method to teach. So this is an illustration of how to use the standard days method. So for the cervical mucus method, there are two ways, Billings method and 2-day method. This is based on the presence or absence of cervical mucus. So you avoid unprotected intercourse all days with increased thin, clear, stretchy cervical mucus. So, with the Billings method, abstinence is required from the beginning of menses until 4 days after slippery mucus is identified. And then the 2-day method is intercourse is considered if no mucus is noted for 2 consecutive days. So this is the cervical mucus method, no? So this is the time that you can have intercourse because you are not fertile. However, when your mucus becomes stretchy, then that is an unsafe period, especially this one, watery, stretchy. For the calendar rhythm method, this requires counting the number of days in the shortest cycle and the longest cycle during a 6 to 12-month period. So for the shortest cycle, you minus 18 days and that would be your first fertile day. And for the longest cycle, you minus 11 days, then that would be your last fertile days. This is not reliable for women with irregular cycles. This is usually used in combination with other periodic abstinence methods. For the basal body temperature method, special thermometer is used, and this is done upon awakening before rising out of bed. This is due to the progesterone-induced temperature elevation following ovulation. So there is an increase in basal body temperature of 0.5 to 1 degree Fahrenheit. So abstinence is days 1 to through the 3 days of elevated BBT. This is a BBT charting of a 28-day cycle. So there is a sustained increase in temperature from days 13 to 16. So during this time, this is considered the pre-ovulatory phase, which is unsafe. After the increase in temperature, the post-ovulatory phase, this is now considered the safe days. Symptothermal method. This is in combination with changes in cervical mucus and changes in basal body temperature. Abstinence is 12 to 17 days. Now, this is a bit cumbersome. For puerperal contraception, the most common is lactational amenorrhea method. During breastfeeding, suckling disrupts the normal pulsatile release of GnRH from the hypothalamus. Therefore, there is an inadequate LH release, so there is no ovulation. But you have to fulfill the following criteria. You should be amenorrheic, so no menses for the next 6 months. And then you have to exclusively breastfeed for 24 hours. And then other forms of puerperal contraception would be the progestin-only pills, IUD, and the DMPA. Spermicides come in the form of creams, jellies, suppositories, films, aerosol foam. They provide a physical barrier to sperm penetration and a chemical spermicidal action, but however, it cannot provide STD protection. So the active ingredient is nonoxynol 9 or octocinol 9. So maximal effectiveness is 1 hour. This is for temporary protection for women. For those victims of rape, hormonal emergency contraception can be offered to them. This is usually given within the next 72 to 120 hours, depending on the method used. Mechanism of action would be inhibits ovulation. So another method is coitus interruptus, which means the withdrawal. No, that means to say penis is withdrawn prior to ejaculation to prevent the deposit of sperm into the vagina. Sterilization. For the female, this is called a bilateral tubal ligation. So depending on when it is done, it is called puerperal if it is performed in conjunction with C-section or vaginal delivery, and non-puerperal if it is done anytime unrelated to recent pregnancy. For the male, it's only vasectomy. So puerperal tubal ligation is done in conjunction with CS or vaginal delivery. So this is technically simple since the uterine fundus is just below or level of the umbilicus and the fallopian tubes are accessible beneath the abdominal wall. In non-puerperal tubal ligation, this is quite difficult because this is the time unrelated to recent pregnancy. So you have to look for your tubes through either a mini laparotomy or through laparoscopy or hysteroscopy. So in here you use permanent rings, clips, or inserts to the fallopian tubes. But several methods of doing a bilateral tubal ligation. So we have a convectomy, Pomeroy, Parkland, and this is with the use of the rings, clips. Female sterilization can also have its own complications, no? Or contraceptive failure. For the puerperal sterilization, there would be a possible surgical error, transection not of the fallopian tube but of the round ligament, or there is a fistulous tract or spontaneous anastomosis may form between the severed tubal stumps. And for the non-puerperal would be related to the equipment failure or fistula formation, or maybe because it is done not immediately after delivery, patient may be pregnant at the time of surgery. For vasectomy or male sterilization, the vas deferens lumen is disrupted to block the passage of sperm from the testes. So for male sterilization, we have vasectomy. This is considered safer than female sterilization because it is less invasive and can be performed with local analgesia. However, sterilization is not immediate because it would take about 3 months or 20 ejaculations for the complete release of sperm stored beyond the interrupted vas deferens. So the long-term effects, which are rare, is chronic scrotal pain and of course regret. So this is how it is done, no? The vas deferens is cut on both sides, of course. Vasectomy failure rates include unprotected intercourse immediately after, or probably there's a incomplete occlusion of the vas deferens, or there is recanalization just like in BTL. So these are the proposed strategies to provide for the unmet needs of family planning services in this pandemic. So probably give contraceptive consultation by phone or video encounter, or they can provide home delivery of pills or condoms. And then PAPCOM also, I think, already has an FB group. And then health centers should be open to give injectables. So this is the end of my slide. Thank you.